Today, we're very lucky. We've got two of our mentors, as you're aware. Mr. Mahmoud Rahuma is one of our senior mentors. He's going to finish the clinical examination part 2. That's coming on later on, but first we have a 20 to 30 minute presentation by Mahmoud Rahuma, who's going to do principles of limb amputation presentation. As always, if you want to ask a question or if you want to make a comment, please do so through the chat or raise your hand in the participant group. And we will need volunteers for the second session where we're going to practice the clinical examination, like we did the history examination of the hip last week. So if you don't mind, please raise your hand or make it known to me in the chat that you want to participate. It's my pleasure to introduce Mahmoud Rahuma, who's going to talk about principles of limb amputation.
Good evening, everyone. This talk about principle of limb amputation. The reason I chose to talk about this topic because it was my first trauma viva in the exam, and also I believe every trauma orthopedic surgeon should have some knowledge about this topic. So surgical amputation is one of the oldest surgical procedures. It can lead to high morbidities and mortality. The learning objective of this talk to understand the indication for amputation, how to decide about the level of amputation. We'll touch on the surgical technique and goals of surgery, rehab process, and complications. This epidemiology slide, based on UK data, lower limb amputation present 91% of total amputations. The common cause is peripheral vascular disease, 52%, 42% of them have diabetes. Trauma, which is our topic today, 11% of the total numbers, and tumor about 3%. The most common level of amputation we may refer to prosthetic and amputee rehab centers is transtibial, is about 50%, and transfemoral about 35%. In terms of causes of amputation or causes lead to amputation, as you can see, it's a long list. But just to familiarize yourself about the causes, and you have something to talk about if you face scenario in the exam. So I will just focus on the trauma cause. You can divide it or subclassify it to acute, subacute, or chronic. In acute trauma situation, the time of amputation can be within hours as part of damage control orthopedic, or you have to wait a few days until you identify the zone of injury and the zone of soft tissue injury and margin of the injury, so you can decide about the level. In terms of the indications, there's 3 clear indications to consider amputation. First one is unreconstructable bone or soft tissue, irreparable vascular injury, and severe loss of plantar foot skin and soft tissue. Initially, absent plantar sensation does not predict the poor functional outcome. As we know, there's some studies shows 50% of patients by 24 months from the initial injury, they manage to have full recovery. This very popular, simple score you can use to decide about, it's not actually to decide, actually to help you. It doesn't work in isolation. You have to look to other things as well to consider when you decide about amputation, like patient pre-injury level of activities, ability of the patient to learn new skills, limbs and trunk coordination, etc. But what I like about this scoring system, it's simple to remember. The parameters is just only 4, and they do make sense. So if you look to the first parameter, they look to the mechanism of injury, if it's high energy trauma or low energy trauma, and the effect of the level of the injury on the soft tissue state. The second parameter, it's the patient hemodynamic state. if the patient the hemodynamic is stable, develop transition to hypotension or prolonged hypotension. Also, the third parameter, which is the most important one, to look to the ischemia. And you can see there's 4 categories. And if the ischemia more than 6 hours, you multiply the figure by 2. And the last parameter is the patient age. We know young patients, also children, have high potential for healing. I think this is the most important piece of information. This talk is about energy consumption following amputation. I'm sure all of you guys are aware of this piece of information, and I think it's very important for people doing the first part of the exam. As simple as like if more proximal amputation you do, the energy consumption will be higher. If you compare long transtibial amputation, the amount of energy consumed is 10% compared to average transfemoral 65%, and bilateral transfemoral more than 300%. So bear that in mind. In terms of like optimum level of amputation, this illustration of common levels of amputation. If you look to the transradial or forearm amputation, the ideal or the optimal level is the junction between the proximal 2/3 and distal 1/3. Transfemoral at the middle 1/3 of the arm. Transfemoral is the same as the transhumeral, and the transtibial, you need to remember this equation. It's 8 centimeter per meter height from the medial joint line. For example, if the patient 180 centimeter height, so you'll be thinking about 14.4 centimeters from the joint line. There's a technique of disarticulation is an option when you cannot achieve an adequate below knee stump. It has advantages and disadvantages. The advantages, it's simple to do. You don't need to cut through the bone or the muscles. Basically, you cut through the ligaments, and it's a quicker technique or option to consider. Also, you don't need to worry too much about the balancing the muscles of the thigh. And generally speaking, the stump healed quicker. It's provide the patient with a longer lever arm when you compare it to above knee amputation. Also provide a large surface area for weight bearing and bulbous of shape of the stump assist to suspend the prosthesis. Also is a feasible option in children because it's overcome the issue of bone overgrowth if you consider transosseous amputation. The disadvantages of this technique, you have limited options in terms of the prosthetic, and also seeing patient slow walking in speed in comparison to below knee amputation. So the amputation itself, you can classify it to 3 phases: pre-amputation, the surgery itself, and post-amputation. It's like what we do when we plan for any surgery. For example, knee arthroplasty, you plan the surgery, pre-operative, intraoperative, and post-operative. Pre-operative, in trauma situation, it has to be 2 consultants' decision. You can't not decide on your own about the amputation. And this, the both guidelines, and this very important to remember in terms when you're creating discussion if you face such scenario in the viva. And also it's advisable to get opinion from a consultant in rehabilitation medicine specialized in the management of amputees. It can help you to decide about the level of amputation. However, this option can be difficult to achieve in emergency situation. Also, you have to consider therapy program should be started preoperatively to establish the basis of the post-operative rehab and what the patient's needs following the surgery. MDT approach achieves the best outcome following the surgery, and also preoperative pain control is essential, including preoperative epidural anesthesia. In terms of surgical technique, as we mentioned, you think about the level of amputation. Also, you have to think about other things. You have to think about the skin incision, how you're going to design the skin incision, so the scar to be away from the weight-bearing area, and also the scar should be mobile, it doesn't lead to joint contraction, etc. Also, you have to think about other structure, like what you're going to do about the muscles, what you're going to do about the nerves, the vessels, the bone, and wound closure. We're going to talk about each one briefly. In terms of the skin incision, use the rule of 1/3 and 2/3 method. Basically, you measure the leg circumferential and you divide it by 2/3 and 1/3. The 2/3 use it for the anterior transverse part, and 1/3 for the posterior flap. The posterior flap should be thick musculocutaneous flap. If you have any doubt, you could go with the longer posterior flap. If there's adequate soft tissue at the end, you trim and adjust as required. In terms of the muscles, there's a few options. One option is called myofascial closure. When you cut the muscle, you close the fascia of the muscle, or you stitch it to surrounding tissue. It doesn't provide stability or add stability to the stump, but this is something to think about. The second option is myoplasty, when you stitch a group of muscle to another group. For example, if you're doing above knee amputation, you could stitch the anterior muscle group to the posterior compartment muscle group to create a padding around the bone end, and also bulk for the prosthesis socket to fit in. The third option is myodesis, when you stitch the muscle to the bone, and should be performed when the proximal joint in full extension to avoid to avoid joint contraction. For example, if you're doing above knee amputation, you need to make sure the hip in full extension. Otherwise, this will lead to fixed flexion deformity of the hip. And the fourth option is tenodesis, you stitching the tendons to the bone. So I like this illustration, it's quite nice illustration. So this adductors myodesis is commonly done for above knee amputation. And the idea here is to balance the abductors hip muscle force by stitching the adductors to the bone end. And also, as you can see, is provide the padding and cover to bone end. In terms of the nerve, should be cut cleanly under gentle traction. The idea is not to prevent the neuroma. The neuroma will neuroma formation is inevitable, but the idea to keep the neuroma away from the stump and the weight-bearing area, otherwise will be very painful, and the patient cannot tolerate to weight bear in the stump. The vessels should be managed and meticulous hemostasis achieved for clear reasons to avoid infection and hematoma formation. And the bone should be beveled. The closer, you should close layer by layer, avoid using non-absorbable sutures, because this non-absorbable sutures will cause irritation to the tissue and the skin, and this can be very painful, except you can use non-absorbable sutures for the skin. This Ertel amputation is a technique well known, and the idea of this technique to create a large weight-bearing area or surface at the end of the stump is based on creation synostosis between the fibula and the tibia. And this X-ray is slightly modified technique because they used tightrope. The initial technique is based on medial periosteum fibula hinge, and you can fix it to the tibia by using stitch or K-wire. There's some studies compare this technique to the normal technique without synostosis and shows there's no difference, but I believe there is some RTC going on to look to the difference. Science amputation is commonly used amputation when you have to consider foot amputation. It's a disarticulation type of amputation. Is based on anchoring the heel with the fat to the tibial plafond, and also to excise both medial and lateral malleolus. The advantage is provide more extended lever arm. Again, is back to basic science and biomechanic. Longer lever arm, you have a better quadriceps muscle function, and also you preserve energy consumption. Patients require less rehabilitation with this technique, as you putting on the stump the thick plantar skin, which is designed for weight bearing. Now we're talking about the post-amputation phase. You have to make sure the patient has adequate post-operative analgesia. Is essential to avoid severe pain, and also you have to consider using neuropathic painkillers. Also, early involvement of the pain team is advisable. All amputees should have access to physiotherapy, occupational therapy, and psychological support. The rehabilitation process aims to achieve maximum functional independence. Early fitting of the prosthesis within 60 days improves the function and speed return to work. This list of people involved in the, or subspecialists involved in the prosthetic and amputee rehab center. You see, it's a big team, consists of consultant rehab medicine, prosthetist, physiotherapist, podiatrist, nurse, psychologist support, rehabilitation engineer, and employment advisor. In terms of the complication of amputation, I like to divide it to local complication and systematic complications. Easy for me to remember. Local complication related to the stump itself. Is, at the end of the day, is surgery with. So the common risk you have to think about: infection, hematoma formation, wound breakdown, skin ulceration, callosities, and scar-related complication. Heterotopic ossification is not uncommon complication. It can happen, and one of the reasons for stump revision. Phantom sensation, when the patient feel part or the whole limb still there, and other possible complications, phantom pain. Not fully understood, but I believe is related to neuroplasticity. Painful neuroma and choke syndrome. As I mentioned, painful neuroma is inevitable, but the only way it could help just to make sure the nerve ends away from the stump. And there is some technique you could inject local anesthetic during surgery to make sure the pain under control in post-operative period. If the patient developed painful neuroma, one of the known technique, you can go and dissect the nerve more proximal, lead to another neuroma away from the weight-bearing area. Choke syndrome is about when the veins around the stump get occluded due to uneven pressure while patient load in the prosthetic, and this can lead to skin breakdown and skin ulceration. In terms of systematic complication, I think about it the same way when I think about hip arthrodesis. Can lead to lower back pain and contralateral side leg pain and hip and knee pain. Other systematic complication, as we know, psychological and mental health issues. And despite the energy consumption with limb amputation, cardiovascular disease and weight gain happen due to reduced level of activity. So it's advisable for this group of patients, they have a long-term follow-up with a cardiologist, and they have regular monitor for their blood pressure. This X-ray shows above knee amputation. As you can see, patient developed heterotopic bone ossification. As I mentioned, it's one of the common reasons to revise the stum. In summary, plan the level of amputation carefully, take into consideration patient needs and comorbidities. Collaboration with a plastic surgeon and a vascular surgeon is essential for a good outcome. Maintain joint function when possible. So when you think about level of amputation, if you decide to go below knee amputation, you have to consider the state of the knee function, if the patient already has got pre-existing fixed flexion deformity or severe arthritis in that joint. So that might change your decision. Aim to achieve pain-free residuum, able to function. MDT approach essential for successful outcome. Thank you.
Thank you very much, Mahmoud. Is there any questions, anyone? So one question from Zanel says, why does the bone need to be beveled for amputation?
Basically, it's to avoid sharp edges, which can lead to local irritation, and also it'd be easier to get adequate soft tissue padding over the bone end.
Questions.
Yeah.
So in the exam scenario, what are the key points to make sure that you mention buzzwords?
First of all, you have to mention its MDT approach. You have to think about, consider independent second consultant opinion. Ideally should be from different specialty like a plastic or vascular surgeon. You have to talk about level of amputation and the reason for that. You have to talk about how you prepare patient for surgery if it's trauma scenario and patient presented with mangled limb. And also you consider all the things we talked about in terms of scoring system. You don't need to remember the score in details, but you just at least you ask in these specific questions. What's the mechanism of injury? What's the age of the patient? What's the ischemic state when the patient arrived to the hospital? Is the patient in shock? So these are all relevant questions. So help you to start the viva and build up and progress.
Yeah. Also, we've been joined by Chikan Georgi. He's one of our mentors as well. Other things I'd like to point out is this scenario can come in the mangled extremity trauma scenario, and it's very important not to focus straight away on the mangled extremity and focus on ATLS instead. Patients tend to throw a picture of a mangled extremity, and you'll get excited about that, and you'll forget to talk about ATLS first.
Yeah.
If the marking's in the ATLS, they'll let you continue. If the marking's in the actual discussion of mangled extremity, they'll tell you this is an isolated injury, or so don't worry about that. Decision making in those extreme scenarios, there's a couple of things. An insensate foot is not necessarily an indication to amputate in the early stage. It has been shown not to make any difference. So waiting for better to try and salvage if you can. Decision to salvage is made between 2 to 3 consultants, depending. So you'll need at least a decision between you and the orthopedic and the vascular surgeons about viability of salvage limb versus amputation. Any further comments, Mahmoud? Any of the mentors?
Yeah, I totally agree with you. Like sometimes can be difficult decision, and you don't want to take that decision your own. So you have to talk with other consultants from different specialty, and also to show you understand the principles, the guidelines. You might ask about the rehab process, which we covered to some degree in terms like pain management, MDT approach, early physio input, occupational therapist input, etc. But I totally agree with you. Like if you present with trauma scenario, you have to talk about the basics first. Like first you want to save life, and after that you think about saving limb. If you cannot save the limb, you have to think about what's the other options in terms of like amputation, vascular reconstruction, and you have to pack your decision what you think is ideal or like appropriate for that scenario.
Exactly. And the importance of MTT discussion in the elective scenario, in the non-emergency scenario, and the approach of who's involved in care. That drop-down list that you had was very nice. I like that. Thank you very much.
Have a good evening. Bye-bye.
Bye.